I'm going to be talking about pre-hospital management considerations for acute coronary syndromes. So what'll happen is you will watch this presentation, and then following this presentation you will complete a small exercise where you'll have to answer some questions. Once you complete that exercise, what I'd like you to do is I'd like you to type that up on Word and then save that as a Word, RTF, or PDF file, however you want to do that, and then email it. And if you could, email it to me at this address down here at the bottom of the screen, all lowercase cbare@nmsu.edu, and then just put pre-hospital management considerations for acute coronary syndromes as the topic of that email. That lets I get lots of emails, so that lets me know that this is part of your assignment for the paramedic refresher course. So this lecture is designed to fulfill part of the requirements for the airway, breathing, and cardiology section of the refresher. And what I'm going to do is I'm going to talk a little bit about the basic management considerations for acute coronary syndromes, and then we will kind of work through some of the new changes that have occurred, primarily with the American Heart Association recommendations regarding acute coronary syndrome. So we'll go ahead and just start the keynote here. Okay, so pre-hospital management considerations for acute coronary syndromes. My name again is Christopher Bear. There's my email address, and there's the college. Okay, so I want to quickly talk about the objectives for this short presentation. I want to review the three basic types of acute coronary syndromes. I want to review the basic findings associated with acute coronary syndromes. These are more general objectives. Review general treatment modalities, and then review any of the special considerations or some of the major special considerations that you can run into in the pre-hospital environment. Okay, so what is an acute coronary syndrome? Well, acute coronary syndrome is essentially a group of conditions that results from the disruption of plaque within a coronary artery. Okay, so the typical case goes like this. I have a coronary artery, I have some measure of atherosclerosis, and that is a buildup of plaque in that coronary artery. And for a variety of reasons, some that we don't understand particularly well, that plaque can be unstable, and that plaque can then rupture. The rupture of that plaque generally exposes collagen within the coronary artery, and the exposure of collagen then activates what's known as a clotting cascade, and a series of events occurs that essentially causes a big clot to develop in the coronary artery, and there is an occlusion, and then everything distal to that occlusion rather quickly becomes ischemic, and then that of course can move on to injury and necrosis. So there are three types of acute coronary syndromes, and they're very difficult to differentiate in the hospital, let alone in the pre-hospital environment. So the initial treatment modalities for all three types are very similar. However, when we actually have a working diagnosis, generally in the hospital, or if you are transporting somebody out of the hospital to another facility and you have a working diagnosis, the treatment does differ somewhat between the three acute coronary syndromes. So I just want to go ahead and briefly cover these, and I'll cover these in accordance with the new American Heart Association guidelines on acute coronary syndrome. So generally what happens is if somebody presents and they have any kind of symptomology that suggests myocardial ischemia or possible infarction, we need to do a very rapid assessment. And this is really nothing different than what we've always done in emergency medical services. Do an initial impression, a secondary survey with a focused exam, you get your sample history, your OPQRST, etc. Obviously, you want to get them on a monitor very quickly, and you want to obtain a 12-lead ECG. 12-lead ECG monitoring and interpretation, or at least an impression, should be a priority assessment intervention in a patient with suspected acute coronary syndrome. In the hospital, the gold standard is a 10-minute door to 12-lead time. That is, within 10 minutes, somebody who presents with symptomology suggesting acute coronary syndrome must have a 12-lead ECG done, and that 12-lead ECG must be read and interpreted generally by a physician who is competent to interpret ECG evidence. So clearly that is important for us in EMS as well, and that should be one of the first assessment interventions that we do. Now, clearly, if the patient is in a significant hemodynamic distress, stabilizing or attempting to stabilize whatever distress they're in is going to take precedence, but obtaining a 12 lead ECG is still a critical component of the assessment initial management of somebody with a suspected acute coronary syndrome. Okay, so when we look at the ECG, based on ECG evidence, we generally will classify these patients into one of the three categories: in the stable angina, the non-ST elevation MI, or the non-STEMI. This was at one time, going back to the 2005 AHA guidelines, was known as a non-Q wave MI. And then finally the STEMI, or the ST elevation myocardial infarction. So kind of how do we differentiate these? Well, the big thing in a pre-hospital environment is we look for elevation of the ST segment. And if you have greater than 2 millimeters of J-point elevation from the baseline in a single lead, that is indicative of a STEMI, acute coronary syndrome. Or if you have greater 1 millimeter or greater ST elevation in 2 or more contiguous leads, and you have a patient with signs and symptoms suggesting acute coronary syndrome, that is also indicative of a STEMI, or an ST elevation myocardial infarction. Now, you can also have other changes. You can have hyperacute T waves. You can have T wave inversion, ST segment depression. These are all things that indicate a certain type of ischemia, or ischemia is occurring. And in patients that have ST segment depression, T wave inversion, and so on and so forth, it'll be very difficult to differentiate those. Usually differentiating a STEMI is fairly straightforward, but telling unstable angina from from non-STEMI, non-ST elevation MI, is going to be rather difficult in a pre-hospital environment, even in the hospital environment. The good thing is the initial management for all three types of acute coronary syndromes will be very similar. So just a quick note on the pathophysiology. So you can see a picture here, and basically this picture is of the clotting cascade, and I've kind of simplified it a little bit. And on the left-hand side, you basically have two pathways to the golden brick road, if you will. You have two pathways that can lead to the common clotting pathway. And at the end of the day, if you look there at the bottom right, at the end of the day, you get a fibrin clot. And the fibrin clot that develops is a problem, particularly in acute coronary syndromes. Not so much in, say, trauma or bleeding, where you want clotting to occur. You have two ways of kind of kicking the whole thing off. The first way is you can have damage to the tissues surrounding blood vessels. Damaged cells will release tissue factor. Tissue factor then activates some other factors, specifically clotting factor 7, which is turned to 7A, and then that then in turn activates the common pathway, which leads to fibrinogen and a fibrin clot. The other way is the way that we are more concerned about in the presence of acute coronary syndrome, and that is damage to the blood vessel itself will activate a series of clotting factors, and you can see them there, and it's pretty much the same thing. One clotting factor is turned into another, it activates another, and so on and so forth. And essentially we go into the common pathway there, and the same thing happens. Fibrinogen is converted to the fibrin clot. So with plaque disruption, we have the right-hand side of the pathway being disrupted. The right-hand side of the pathway is what's known as the intrinsic pathway, because it's within the blood vessel, and the left-hand side is the extrinsic pathway, which happens outside of the blood vessels. And some of the medications that we give to prevent clot formations can work in, some are very specific to the intrinsic, while others are very specific to the extrinsic pathways. The end result, of course, is going to be acute myocardial ischemia, sudden deterioration, obviously because I have disruption of blood flow and perfusion to the heart itself. This differs significantly from a patient with, say, stable angina. This is somebody who we know they have angina, they overexert themselves a little bit, they rest, they take their nitro, and they get better in about 15 minutes or less. That kind of patient doesn't have the pathophysiology that we see in acute coronary syndrome. That kind of patient has a plaque, does have a plaque, and that plaque does decrease blood flow, but the plaque isn't ruptured, and there isn't a complete or near total occlusion of the lumen of the coronary arteries. That's the major difference between stable angina, where I have a partially occluded coronary artery, I have decreased perfusion, but I'm still getting perfusion through that. And I only have problems when I overexert myself, versus acute coronary syndrome pathophysiology, where I have a total or near total occlusion with a significant amount of ischemia that doesn't resolve with rest and nitroglycerin. Okay, so assessment and basic findings. All the typical assessment modalities apply, just like I said earlier: sample, OPQRST. There are a few unique assessments that are critical to institute. Obviously, we need to obtain a 12-lead ECG very quickly. 10-minute door to 12-lead time is what we shoot for in a hospital. So we should shoot for something very similar in a pre-hospital environment. Within the first 10 minutes of looking at a patient and beginning initial assessment management, we need to have a 12-lead done on that patient. Additional questions to gather. Specifically, if you are in a rural area and you won't be able to get the patient to a cardiac cath lab in a timely manner within 60 to 90 minutes, that patient is obviously, the sooner that we can get somebody to a cath lab and the sooner we can perform an intervention and reestablish circulation, or what we call revascularization, the better the outcomes are. In the absence of having the ability to do that quickly or efficiently, we may need to consider giving fibrinolytic medications or the clot buster medications that can break that clot down and kind of decrease some of the morbidity and mortality associated with ischemia or ongoing ischemia, injury, and necrosis. So some other questions that you want to ask, particularly if you're in a rural environment, which I understand you guys are in Ruidoso, which can be exceptionally rural and exceptionally prolonged to get patients to definitive care in certain areas there. So you definitely want to ask some questions about fibrinolytic candidacy and ruling them in or out. So here's a list of some of the big questions that you want to ask regarding if somebody is or is not a fibrinolytic candidate. You want to ask them if they've ever had any brain or spinal surgery. Clearly, if they've had that, they're going to be at a much increased risk for having bleeding either in their cranium or possibly bleeding in the spinal cord or within or under the meninges. Also, asking about something known as an AV malformation. That's an arterial venous malformation or a tumor within the cranium. Obviously, these will significantly increase the risk for intracranial hemorrhage. If anyone has had any history of a stroke, and that includes history of ischemic stroke, you're going to be at much higher risk for intracranial hemorrhage. Possibility of pregnancy. Pregnancy isn't necessarily a absolute contraindication, but clearly it does complicate the picture a little bit. Uncontrolled hypertension, particularly if you have tried to control hypertension or decrease that blood pressure a little bit, and that patient is refractory to your interventions, that again will increase the risk for intracranial hemorrhage. Obviously, active internal hemorrhage or recent surgical procedure is going to be a problem. And then anticoagulant use, such as low molecular weight heparin or Lovenox, Plavix, aspirin, heparin, and Coumadin. Now, anticoagulant use is not a contraindication. It is just a caution. Clearly, there may be some additional side effects associated with fibrolytics and anticoagulants, but don't think that if someone is taking aspirin or Plavix or Coumadin that they're necessarily contraindicated to use be administered fibrinolytic therapy. Okay, so real quick, paramedics tend to be very good at this, so I won't spend a whole lot of time here. Generally, paramedics are very good at lead localization, on the 12 lead, and this is more, I find anecdotally, this is more of a nurse issue where you have to spend a little more time with nurses that may not be as comfortable looking at 12 leads. So the way that I always look at the 12 lead is I say the phrase, I see all leads. And I start at I, and that's the inferior wall, and that typically involves the right coronary artery, the RCA, and those are the leads 2, 3, and AVF, so 2, 3, and augmented vector front. And you can see I actually have a 12 lead ECG here, and if you look at kind of the pink area there, you have leads 2, leads 3, and AVF in the pink area, and those indicate the inferior wall, specifically the right coronary artery. And then I move to C, which is a septal wall, which specifically involves the left coronary artery and the branch of the left coronary artery known as the left anterior descending. Those are V1 and V2, and if you see the little blue color there, those are generally where leads V1 and V2 live. And then I move on to the anterior wall, V3 and V4. This is also the left anterior descending artery, and you can kind of see that as the orange looking area there. And then last but not least is the lateral wall, which isn't labeled on this slide, but the lateral wall is basically what's left over in the green. And those are the leads V5, V6, 1, and augmented vector left. So V5 and V6 are underneath V4, and then you got to go up to the very top left. You have lead 1 there, and then kind of right in the middle you have AVL, augmented vector left. And you can see that AVR there on top, or augmented vector right, kind of gets left out because it doesn't really look at significant areas of the heart. It's more looking kind of at the aorta, so we don't typically use it in our assessment of the 12 lead ECG. Okay, so just as I talked about a little earlier, ST segment elevation in 2 or more contiguous leads, or new onset left bundle branch block with or without Q waves in the presence of cardiac signs and symptoms suggests STEMI. Q waves, of course, are right after your P wave and at the very beginning of your QRS. You generally have a little dip in the baseline, and that's called your Q wave. And then the R wave as the QRS goes up, and then of course the S wave as the QRS goes back down. Generally, those little dips in the Q waves are generally very small. If they become very large, 1/3 to 1/2 the size of the entire QRS complex, or as long as a QRS complex, that indicates that necrosis, actual death of the tissue, has started. So basically, when you talk about the evolution of an acute coronary syndrome, specifically the ST elevation myocardial infarction, generally you have different phases. The first phase is you develop ischemia first. And ischemia, they say, starts off with hyperacute T waves, and these are really tall, kind of peaked T waves that kind of look like hyperkalemic T waves. This generally doesn't last very long, and I've never seen it because it apparently is such an early finding that you rarely see it by the time you get to somebody. But then you transition from hyperacute T waves to ST depression and T wave inversion. So then your segments become depressed, and that indicates ongoing ischemia. And then as the heart cells become injured, they actually are becoming injured due to lack of perfusion of oxygen. Then the ST segments go from depression to elevation, and when I have elevation, that's where I have injury. And then as an injury goes on, I end up developing the Q waves as I start to have death of the myocardium itself. So generally the 3 things that you'll see as the STEMI evolves is you'll see ST depression or T wave inversion, ST elevation, and then the presence of Q waves. Non-specific changes, depression, or even ST elevation may be associated with unstable angina or non-STEMI in some cases. Use of fibrinolytics to treat acute coronary syndromes other than STEMI. So we don't typically use fibrinolytics to treat unstable angina or non-STEMI because there tends to be increased risk of intracranial hemorrhage in those patients. And then just remember the ICL leads for localization. So if you look at this 12 lead that I actually took a patient that I flew some years ago, If you look at leads 2, 3, and augmented vector front, obviously you have significant ST elevation there. So you can already say that the the right coronary artery has been taken a hit and the inferior wall is involved. Also, if you look at V4, V5, V6, you have V3, 4, 5, and 6. You have pretty significant elevation in those leads as well. And that obviously indicates that the anterior septal wall and part of the lateral wall has been involved. So I have a multi-vessel infarction occurring, and then the depression in V1 and V2, that significant depression, can either be what we call a reciprocal change, or it can also indicate the presence of a posterior wall MI. So I pretty much have a very sick, very nearly dead heart here. Okay, so general treatment. I want to talk a little bit about oxygen. The guidelines on oxygen have changed a little bit. And all the evidence that's coming out of oxygen really indicates that we tend to over-oxygenate patients, and this can lead to some problems due to the formation of what are called free radicals, or radical species of molecules. And these free radical molecules really like to gobble up electrons, and when they gobble up electrons, they're highly reactive. Obviously, this damages cells. And the more oxygen I give somebody, the more free radical formation I can have develop. So the general rules now are, if your patient is doing better than 94, 95% or better on their SpO2 on room air, you do not have to administer supplemental oxygen. Now, clearly, I'm not telling you to break your protocols. What I'm doing is I'm just saying, hey, these are what the new national guidelines, this comes from the American Heart Association, based on a significant amount of evidence and research. This is what they say. Aspirin or acetylsalicylic acid, if not contraindicated. Aspirin is actually one of the only pre-hospital interventions that has been shown to be of any benefit to patients experiencing acute coronary syndromes. So things like nitroglycerin and morphine and all that don't necessarily improve morbidity and mortality, but aspirin does. So aspirin is, believe it or not, going to be one of our most important pre-hospital modalities. Obviously, we need to make sure there are no contraindications. Nitroglycerin if indicated, pain control if indicated. Generally morphine has been the go-to medication. If you're concerned about hemodynamic instability, you can consider a medication such as fentanyl. It doesn't affect the hemodynamics as much. And then the role of beta blockers and ACE inhibitors. In years past, the role of beta blockers in acute myocardial infarction management has been very important, and that was actually one of what we call a core measure in the hospital. That it is something that has to be done, and we were having to give beta blockers, intravenous beta blockers, very early on in the management of acute myocardial infarction management. And you guys may actually remember administering IV beta blockers in the field on MI, patients experiencing MI. Now it's changed somewhat. Beta blockers are still important, because they decrease the heart rate, they decrease the incidence of harmful left ventricular remodeling that can occur after a myocardial infarction. But you don't necessarily need to give them within the first few minutes of an MI. You have about 24 hours to initiate beta blocker therapy, and this can be done orally. The same can be said of ACE inhibitors or angiotensin-converting enzyme inhibitors. ACE inhibitors also have been shown to be beneficial in preventing ventricular remodeling, and obviously ACE inhibitors can be very important when it comes to managing congestive heart failure. Okay, special considerations. This has actually been pushed pretty hard very recently. It wasn't always the case. We know that the right coronary artery supplies the inferior wall that leads to 3 AVF. If somebody has an inferior wall myocardial infarction, there's about a 30 to 50% chance that they will also have a right ventricular infarction, because the right coronary artery normally supplies the right ventricle. Okay, if I have an inferior wall STEMI, I must check the right ventricle. I must rule out right ventricular infarct, or RVI. And the way I do that is I simply take V4, where it normally sits on the left side, and I move V4 to the right side. I run my 12 lead again, I circle V4 and write an R next to it, and you can see in this ECG down here, I've done just that. I've run the 12 lead and I've obtained what's called a V4 right, or a V4R. Once you do that, look for ST elevation. If you see ST elevation and V4R, you have a right ventricular infarction, and you can definitely see there's significant ST elevation there. This is quick, it's easy to do, and it is about 90% sensitive and 90% specific to the detection of a right ventricular infarction. Why do we want to rule that in or out? Well, if I have a right ventricular infarction, that means that the right ventricle will not be able to adequately accept venous blood from the body. And the problem with that is the right blood will back up, obviously, and I can have right heart failure, but the problem with that is you need the right ventricle working to pump blood over to the left ventricle. And if you lose your right ventricle, or it doesn't work very well, then the heart loses its preload. You can't adequately preload the left ventricle, and your overall cardiac output is going to fall. You're going to have a low blood pressure, and obviously you can have bradycardias and heart blocks, because those are very common in inferior wall STEMIs due to the fact that the right coronary artery supplies the SA and AV nodes with perfusion. So if I take out the right ventricle, or it is infarcting, medications that decrease preload, such as nitroglycerin and morphine, may be contraindicated in these patients. In fact, you may need to give these patients a fluid bolus of 1 to 2 liters to augment preload, in essence, force fluid through that right ventricle and get it into the left ventricle. Okay, so that's a very special consideration for inferior wall MI. Posterior wall MI. Posterior wall MI, if somebody has a posterior wall MI, we know that's important to kind of find, because that increases morbidity and mortality of patients. Their chances of dying increase with posterior wall MI. And the best way to identify posterior wall MI is if you see your leads V1, V2, V3 sometimes, if you see those leads with very significant ST depression in the presence of an inferior wall MI like we have here, that depression can either be what's known as a reciprocal change, or it can indicate the presence of a posterior wall MI. If you really definitively want to identify posterior wall MI, what you can do is you can take your leads, take your V leads, V1, 2, 3, 4, 5, 6, whichever, a few of those leads. Generally what I do is I'll take like 4, 5, and 6 and move them to the back of the chest and place 3 leads. So we'll say V4, V5, and V6. We'll place those 3 leads right underneath the scapula on the left side, run the 12 lead again, circle V4, V5, and V6, and write V7, V8, and V9. And if you see elevation in those leads, that's a definitive indication that there's a posterior wall MI. Now, last but not least, I want to talk about left ventricular failure and cardiogenic shock. If patients develop left ventricular failure and true cardiogenic shock, that'll generally occur if you take out 40% or more of the left ventricle. These patients are typically moribund, they're critically ill, and the mortality rates are going to be very high for patients that have left ventricular failure, acute left ventricular failure associated with myocardial infarction, particularly STEMI. Managing these patients is going to be very complex. It's going to likely involve vasopressor therapy. The standard therapy for stabilizing these patients involved putting a balloon in the aorta, and then when the heart was at rest, the balloon would pump, and that would increase perfusion to the heart and kind of pump blood out to the body. And then when the heart was in systole, that balloon in the aorta would deflate, and the heart wouldn't have to work as hard to get blood out. That's what's known as an intra-aortic balloon pump, or IABP. However, new evidence suggests that IABP therapy is in fact not effective and does not improve morbidity and mortality. And you can actually find this in the New England Journal of Medicine in their newly published, as of October 2012, Shock 2 IABP trial. It's a really interesting read, and it was a prospective randomized study that involved 600 patients. So we now have evidence that IBP therapy isn't as effective as we thought it was. Left ventricular failure is going to be difficult to manage. You could expect pulmonary edema as well, hemodynamic instability. They may even be very hypertensive. It's just going to be very difficult to manage these patients, and it'll involve obviously vasopressors and other medications that increase the inotropic activity of the heart, such as milorone. Okay, guys, so that's the end of this little lecture. It's kind of a short lecture. Here's a reference. One of the major references I used for this is a book, Critical Care Transport, American Academy of Orthopedic Surgeons, Jones and Bartlett Publishers. Major reviewer is Dr. Pollock. Came out in 2011. You're definitely not required to get this book, but this is just a reference you can use if you want to look into more information. Obviously, I did reference the 2010 American Heart Association guidelines. You can download those for free off the internet through the American Heart Association's journal known as Circulation, and of course the New England Journal of Medicine when it comes to the Shock 2 IABP trial. Okay, guys, hopefully you enjoyed this, and hopefully I covered something that was a little new, because that was kind of the point of this particular refresher, is to kind of do something new and kind of add in new material. And obviously we needed to cover, we're looking at covering material that is required for you guys to make the transition from nationally registered EMT paramedic to nationally registered paramedic. Okay, guys, so go ahead and take a look at the assignment that is associated with this lecture. You'll work your way through the questions, type up your answers, and then go ahead and just mail those answers into me. All right, guys, take care.